um, another advocate, and we had a difficult client. So I was like, do you want me to take the lead? Do you want to take the lead? I mean, if you want to take the lead, it's good experience, but I'm with whatever. But I was really like, you take the lead. I don't want to take it. I don't like confrontations.
But you got to observe, your own reactions. I hope your own physical reactions to
Yeah.
crisis. And kind of, were you able to observe like the client move through the phases of the crisis cycle to some degree?
Yeah.
And would you have any feedback for the person? Did you get to watch the person handle the whole
Yeah.
shebang?
Um,
Yeah.
yeah, I think the like we worked on like the de-escalation just because I was like, oh, let's take a minute and we'll come back to it just because um her tone started to change. So it went from like very empathetic to professional to being a little snippy. And I was like, oh.
Yeah. Yeah. And that's, I mean, it is valuable to observe others doing crisis and utilizing crisis. And it's really valuable to kind of identify where the client is at in the crisis cycle. And then at that stage of the crisis cycle, should you be offering options and setting limits, or what should you be doing at that point? And all those nonverbal skills, or those nonverbal cues. I like to think of that professional to snippy change as giving
Yeah.
a nonverbal cue to a client that the client's doing something wrong in some way, and that just increases the level of crisis and the level of um, escalation for the client. And yeah, so you have to pay attention to those nonverbal cues always, because sometimes you're giving them with intent of producing an action or a skill. But sometimes, those nonverbal cues, you don't control them. You're not thinking of controlling them. And you may be telling someone to do something with your face that your body really doesn't want. So
Yeah.
I don't know if you've ever been inside of therapists' offices, but a lot of them have little mirrors on their desk. And that's because most of the time, uh, if you're, some people are working on what their face looks like in their therapy session. So it's an interesting thing. I always have a mirror in my office because usually I have coffee like smeared all over my face from like my morning of drinking coffee. But when I did place a mirror on my desk, it was really interesting what I was reading from my face. So and Crystal knows I have like this permanently busy, focused looking face. And I noticed that I didn't have that with my clients, which was good. So, but it took a little bit of work. So, all right. Well, good deal. I'm glad that you got a chance to get involved in crisis last week. So Chris, if you want to start sharing the slides, it'd be good. So this week we're going to talk about documentation and paraprofessional ethics. And the people with the fancy letters behind their names, they each have a code of ethics that they ascribe to. So social workers have the NASW code of ethics. Um, uh, Counselors have their code of ethics. Psychologists, psychiatrists, etc. And some paraprofessionals do have a code of ethics. In particular, like a community health worker and peer recovery specialists have code of ethics. I don't know if there's a care coordinator code of ethics. So that's some research to do there. Crystal and I are both like thinking, wow, we've been care coordinators forever, but I always what I do as a paraprofessional is that I fall under my agency's code of ethics. And so it's important, if you haven't already, to explore what your agency's code of ethics says. And really just this is really just a, what do you call it? A broad overview, So, All right, Chris, could you go to the next slide? Oh, there we go. All right. Here's what we're doing today. So we're hoping to give you like a basic understanding of the rules for reporting or documenting services and supports that you provide as a paraprofessional. We want to show you how to document services in a way that supports the medical necessity that either a licensed health, I'm getting this wrong, that a licensed provider, whether health or behavioral health, has to begin. They have to document that medical necessity, and you have to support that in the work that you're doing. And then we'll just do a brief overview of some ethics of paraprofessional services. All right. Sound fun? All right. So one of my I don't think it's a secret that one of my favorite roles in health services are paraprofessionals. And that is because I was a very lucky person that that had an experience with mental illness myself. And that doesn't sound lucky yet, but hold on, you'll hear how lucky I was. And I was also working as a trade certified teacher, working towards my master's degree in teaching. And I had a pretty severe episode and was diagnosed with a severe and persistent mental illness. So I dropped into a clinic and was receiving services on my own. And my therapist said, you know what? I know this chick, and she talked to this other short Asian girl that might or might not be on this call. I know this chick that really could probably work with some of the difficult kids that you're working with in the community setting. And so with my half a master's degree and my bachelor's degree, I headed into the world of paraprofessionals. And so the thing is, I would be considered a professional in a different field, right? As a teacher, but I was a paraprofessional because that's a job title that's given to people in different occupational fields. It might be education, it might be behavioral health or healthcare, even law. So like when we talk about paralegals, you think of like that. Those are people that are trained to assist professionals, but are not yet themselves licensed at a professional level. And not, I'm saying not yet, even though the yet's not in there, because it's a common path also to becoming a licensed professional. All right. Slide. Oh, there we go. Oh, yeah. Go back, Chris. My bad. So para in Latin means beside or side by side, right? So paraprofessional, beside, you work beside a professional. All right. Thanks, Chris. And then you're going to have to click a bunch of times, I think, because they're all listed on here. So here's some common types of paraprofessionals. You've already heard me mention some of them. And as these pop up, I want you to let me know, I want you to let me know if you've worked with any of these types of paraprofessionals before.
I don't think I've worked with them, but I've had coworkers who had these titles before, or they were part-time these titles.
Mm-hmm. Mm-hmm.
So I don't think I've
not worked directly with them, but you're familiar with people who have worked in these roles. Okay.
Yeah.
Yeah. So care coordinators, top of the list, man. They are most often bachelor's level, to be honest, most often bachelor's level. And they play a vital role in smoothing out all the plans that the professionals make for the patient, and creating a self-management plan, supporting a self-management plan that for the patient that takes into account, a little bit more of the family's feedback, because you're around them a little bit more. So that's a good thing. Community health workers, peer support specialists, and peer recovery specialists all have a special commonality in that they are all hired because of their training and education in each of these roles, but also they are hired because of their life experience in these roles as well. So a community health worker is typically someone who has had to navigate the health system themselves, or perhaps for a family member. They may come from allied, they're somebody that's worked in, sorry, maybe there's somebody that's worked in a role like a receptionist, or a role where there's been a lot of contact with community members. And so they might also train, but they come from the community they serve. That's most important. Peer support specialists and peer recovery specialists have to have lived experience. First, peer support specialists have to have lived experience in mental health disorders, and peer recovery specialists have to have lived experience in recovery from drugs and alcohol. PSRs and developmental therapists, as you know, in Idaho are certified and typically work in agencies, well, like your own for PSR, sometimes agencies like your own. And developmental therapists are, again, certified through a test at the state level. And there's like an awful like online thing you have to do. Sorry, but I used to be a developmental therapist too, so I can complain about it. But anyway, next slide. So we know who the paraprofessionals are. Who are the professionals? Lots of clicking, I think, going here, Chris. Yeah. So medical doctors, nurse practitioners, physician's assistant, people with graduate degrees in social work and counseling, and those with clinical licenses in psychology, social work, and counseling. So they're the professionals. And the big question is, is always, what can they do that we can't do? Mm-hmm. Right? Because you may have a ton of experience in working with a certain population, but for some reason, they can do some things that we can't. So, okay. So in order to kind of make sure you understand what they can do and what we can't, I'd like to ask you kind of a knowledge check question. What do you know about the hierarchy of documents that have to be present in a client's file in order to provide them with services?
As far as for family health services, I'm not quite sure. For my for another agency I've worked for to get counseling, usually it was like a confidentiality agreement, basic information form. They did an intake kind of like to agree to a standard procedure of like you can't like confidentiality how the sessions work, and then there was a P something. I forgot there was a specific screening. I think it was specific to trauma and depression. But yeah, but I know family services, I think it's there's like the regular, like those intake documents, and then there's insurance documents, and then I believe any other prior medical records, and then they see the therapist here.
Okay. So that intake process, it sounds like you've learned a lot already from your prior experience. That intake process is the prelude to what the professionals have to document in the file in order to provide services. So what they can do that we can't is that they can complete a comprehensive assessment and select from the details, the information in the assessment, an appropriate diagnosis, or a diagnosis that they, a treatable mental health diagnosis, we hope, or an appropriate diagnosis. They also then, after that assessment is complete, whether that's done by a behavioral health professional or a doc, to be honest, they can develop service and support plans. So they can say, you know, let's give an example. I need to see this client 4 times a month for an hour for therapy. And I would like to have this client seen once every 3 months for medication management. And I would like this client to work with our behavioral health care coordinator between 30 minutes a week on monitoring their blood pressure, or on a self-soothing skill, or on, they can choose from all of those things what you can do. So when they develop those service and support plans, that's where Alberto.
We know a Roberto. That's why she keeps saying that.
I know multiple Robertos, and I can roll my R's better with Roberto than I can with Alberto. So, so anyway, so they develop those service and support plans, and that is kind of that is where you are offered a role in their treatment of this client. So it's really cool that they can do that, because otherwise we wouldn't have jobs as paraprofessionals. They can provide therapy, so individual therapy, family therapy, group therapy. Primarily, they can provide types of therapy that are, I'm losing the word, Jen.
Delegated?
Process groups. Sorry, they can also do process groups. The professionals can, but the professionals can also, paraprofessionals can also have groups of their own, and those just can't be therapy groups. So those might be skills groups, those might be educational groups, those might be relaxation skills training groups, they might be cooking groups or activity groups. They can provide therapy. We can't provide therapy, we can do one-on-one services. They can provide professional opinions. So when somebody comes up to you, let's say you're working with a person who has a caregiver in their home, and they say, the caregiver in the home says, you know, I just don't think that any of this therapy that we're giving my mother is helping. Alberto cannot say, you're probably right. All right, you can't do that. Okay, they get to provide all the opinions. Okay, you know, so it's one of those things where they get to provide the professional opinions. You should definitely be giving them feedback so that they can make the best decisions possible, because you're a team member. And the last thing that professionals can do is they can supervise services and service providers. So a professional can supervise you. A professional, somebody higher than me can supervise me. They can supervise the service providers, and they can give you feedback on how to deploy a service to support the treatment plan that comes from the assessment that is driven by a diagnosis. So I'm just going to say this really quickly again, because I know we cover it again, but intake, assessment, service plan, services, right? That is the hierarchy of documents. So services or service notes, that's the basic hierarchy of documents.
And just a quick question, Alberto, are you eventually going to go on to get your master's?
Yeah, I'm planning on it.
Okay, really helpful for you as you learn the paraprofessional documentation, but it really will, you will be, when you go into your master's program, you're going to be actually quite a bit ahead of a lot of people, just knowing what we're training you on, because they actually don't do a very good job of training this particular mechanics on documentation in school.
Oh, okay.
Well, and it also offers you an opportunity, you know, with the professionals, with the professional support or with your supervisor's support, to review assessments and service plans. Because by the time that I got to start writing my own service plans in my master's, first year of my master's degree, by the time I started writing treatment plans and assessments, I'd already read thousands, right? And so, and you're not just reading it for you to learn, you're reading it to learn, you know, in the assessment, what was the problem that was presented, what was the service that was intended to solve the problem, and then the treatment that was intended to solve the problem, and what part of that treatment are you providing in your service as a care coordinator. So it helps you to link that. So that's enough on that though, because they don't get to do a lot of fun things that we get to do as paraprofessionals too. So. All right, next slide, Chris, thanks. So yeah, so paraprofessionals can do everything else as long as this should be pretty much a review, are following a care or treatment plan developed by, oh, I left QMHP in there, dang it. Developed by a professional or provide the service at the specific direction of the professional. Nothing I didn't say, right? They write you into your treatment plan. You can do everything that they can do as long as you've received sufficient training to be able to competently provide the services. So let's say that they would like you to provide a group on healthy eating and diabetes. Something you can do. Are you competent? Can you competently provide that service?
No.
No. And that is our ability to say, you know, I am happy to provide. I love groups. So I always say I'm happy. I'm happy to start a group for the clients that you want to serve, but I really don't have much training in that. Is there someone that can provide me with more training, or can I work with someone to develop the lessons that we're going to give in this group, like a dietitian or another professional? And so, yeah, as long as you have sufficient. So if I told you, hey, Robert, hey, I probably say it every time. If I said, hey, Alberto, I want you to run a relaxation skills group. You think you could do it for an hour a week for 4 or 5 of my clients that all need to learn relaxation skills?
I don't know. Maybe. That seems a little easier.
That seems a little easier. Yeah, it does. And it's still okay to say, you know, I love your ideas, but yeah, I've got a cool book of relaxation exercises. You know, what else would you like me to cover during the group? So, and I love it. Find out who is the group guru or the group nerd, if you think that you would like to do group work, because yeah, and you may get pulled into doing these groups just from the pathways of services that you're involved in. So I think I love groups, love them. I love them. I once drank a half a cup of salsa in a group on a dare because the girls did something that I didn't think they would do. So, Jen doesn't know that, but I have. So I have a lot of fun with my groups. So, and also you can provide the service under the direct supervision of a professional. That means that you report and meet regularly with a supervisor, and regularly is, you know, no less than an hour a week, which ideally, it just must, but ideally should be one-to-one and face-to-face. We know we're not living in that world all the time. You may be working in a different area than your supervisor, but and that supervision might be group as well, you know, as BHCCs or other paraprofessionals join. All right, Chris, next one. All right. Oh, back. Yeah, good job. So this is where we get super nerdy on compliance, which I'm going to ask a question. Jen, will you ask the question about the signing of the treatment plan eventually? Remember that question?
Yeah.
Medicaid? Yeah.
You want me to ask that, or what are you asking?
Yeah, in just a little bit. Yeah. Okay. Because I'm not going to get it right. So when we document the services and supports that we provide as paraprofessionals, every service or support must be documented in a service note. If you didn't document it, it didn't happen. And you definitely want to document what happened, first of all, for billing, second of all, for coordination with other parties, and third of all, it's called cover your buns sometimes, so that you're really thorough in what happened, or that you're not thorough, but you're very clear about what happened. So the service note has to have the name of the person who had the service, your name and credential as the person that provided the service. So your name and credential is Alberto Duran, BS, right? Yep. So perfect. The type of service provided, so that might be care coordination, that might be a skills training group. Basically the CPT code, the CPT identifier of the type of service that you provide. The number of minutes, or where and when the service was provided. We're not talking down to the address, we're talking office, school, community, etc. Care facility. The number of minutes needed to provide the service. If the service was provided over the telephone, an explanation of why it was not provided face-to-face. That goes for video right now as well. It just has to say COVID, pretty much. It just says say for the public health emergency COVID, we met only by phone. So. And enough information in your note to validate that the service was quote unquote medically appropriate. All right, you want to go to the next slide, Chris? All right, so medically appropriate, what in the heck is that? So remembering that under Medicaid, which is, you know, the standard that it's the highest standard, really. Under Medicaid, all services must be medically appropriate. That means that without that service, we may not prevent, or excuse me, that means that that the services are required for the prevention, diagnosis, or treatment of a mental health condition. So that means that mental, no, I'm not going to go there yet because we will go there. It means that the service is consistent with the symptoms of the mental health condition or treatment. So let's say that you're working with someone who has depression, and the service that you're encouraged to provide them is to go and clean their house while they can lay on the couch and sleep all day. Yeah, that's probably not consistent with the mental health symptoms. Just throwing it out there. Consistent with standards of good practice and generally recognized as effective. So the service has some type of evidence base, or some type of logical rationale of how it will produce a better outcome or result. Okay. Not solely for the convenience of an individual or a provider of the service. That means that, you know, clients don't call you up and say, hey, could you come over and rake the leaves in my yard? We can talk about my how I've been doing on my blood pressure monitoring while we're there. That's a little bit solely for the convenience of the person, you know, the client. Or, you know, I'd really like to go with you, Alberto, and talk to you about my blood sugar, but could we do it on a fishing trip? Yeah. And maybe not. That might be a little bit better for the individual, but it can't be for your convenience either, which means, you know, you have an hour pop up in your schedule and you say, oh, I want to be the productive Alberto, and I want to make sure that I get the highest productivity. So I'm going to just squeeze in this appointment. It's not indicated on the treatment plan that I need to meet with this person that frequently, but I'm just going to squeeze in another relaxation skills training call with this individual just because I have an hour open. That's also providing it for your convenience. I mean, if you rescheduled, okay, and it's good for them and it's good for you, great, but it can't be for your convenience. And then it needs to be medically appropriate, means that it needs to be the most cost effective of the different types of services that can be safely provided. So I'm going to give an example of this in the medical world before I give an example in the behavioral health world, okay? So I have a son, he plays 5th and 6th grade football. During the second quarter, he gets his bell rung, which is like kind of slang for mild concussion. And on the scene, people check him out and they recommend that I take him to the hospital and have him assessed. And I get there and they decide to put a halo on his head and screw it all in and go in and cut open his neck and check out all the vertebrae and make sure that there's no broken pieces at the base of the skull, which is usually one of the most dangerous types of neck. So I brought him in for a concussion. They're treating him like there's a neck injury. So it's got to be cost effective of the different types of services. Maybe they'll heal him with his halo and his neck surgery as well. But would it be cost effective, and would it be safe to provide that service? So when you take that to the behavioral health world, it's a little bit different. So case management is something that paraprofessionals will be asked to do at times. If you, as with your level of skills and education, can assist a client in their case management needs, then if the therapist decides that they're going to be with the case management needs, that might be not the most cost-effective way to use therapist services, right? Because they're a licensed professional and they may need to delegate that to someone that has the skills, the training, the education to produce the same outcome safely. Not to say that it's bad for therapists to do case management or behavioral health consultants. They do it too. But when I do case management, it is because, as a therapist, it is because it is a very emergent need and there's safety involved. And I want to take care of that right then. So let me, sorry, anything to share, Jen?
Yeah, let me just to give you another example in regards to medical necessity. Think about it like medication. So even though we're not giving pills to somebody, we're still prescribing treatment, right? So if you think of a, whether it's a psychiatrist or a med provider or a primary care doc, okay, so they prescribe medications to people all the time. So let's just go down the line here. If they prescribe a medication for someone required for prevention, diagnosis, or treatment of a mental health condition. Okay, so let's say they had a diagnosis and then they used the wrong medication for that diagnosis. So for instance, right, this person has a heart condition, but they gave them some sort of medication around lung, right? They don't match. So you got to make sure your diagnosis and medication or prescription matches the disorder that they have. So this would be the same thing as if someone says, I've diagnosed you with depression, but I'm going to only treat you for anxiety, which is a mismatch. So it's really important that what you diagnose matches what you're going to prescribe for treatment. So same thing as meds, right? You're never going to give someone who's got depression anxiety meds, right? So you got to make sure those match. Also, that it's consistent with symptoms of the mental health condition. So within scope, a primary care doc, they do prescribe medications for mental health, but they don't normally treat for mental health, right? They would get a specialist to do that. And so like a behavioral health consultant, and they would determine, you know, hey, as a PCP, I think this person has depression. I'm not the most appropriate person to be doing, you know, individual therapy or behavioral health interventions with this patient, but I can assist them on depression medication, right? So they're within scope. And then it's consistent with standards of good practice and generally recognized as effective. So so we have seen a lot of physicians getting arrested or being charged with prescription abuse, right? So someone has pain and all of a sudden they have oxycodone. And those are not good standards. When you look at not only the evidence, but the USDA guidelines around prescription of opioids, we're over prescribing. So a lot of these organizations are putting, you know, they're dosing people too much with something that could have been just dealt with aspirin or Tylenol, but they're giving them oxycodone. And because it's one, convenient because the patient wants it, and it's making them money as well, which is not cost effective. So what I'd like you to think about when someone does a mental health assessment and then they do a treatment plan and then they add you on the treatment plan, it's just like dosing them with medication. So the assessment is the evaluation to determine how much services, the diagnosis, how severe it is, and how much services they're going to need to help abate or prevent those symptoms to get worse, right? And then what they prescribe is the prescription pad. So you being on there is a dose of treatment. And then what they actually deliver, so you deliver, matches everything that they did on the assessment, saying, hey, this is medically appropriate for Alberto to be in here because I prescribe this because it will particularly help with this person's mental health issue or needing care coordination to help them with something around their mental health condition. So you're specifically focused, targeted for that particular diagnosis and symptom. And then you are dosed. And then if you overdose, underdose, right? Depending on the severity, the physician or the BHC is going to have to determine how much dosing this person's going to need. So when you move into a master's program, this is something you have to think about. We see in our profession, Crystal and Megan and I, we see therapists overdosing and underdosing patients because they don't understand this medical necessity issue. So that's why you have to be a good, as you're working as a paraprofessional right now, really understanding how a clinician justifies medical necessity. How do they document to that? Are they meeting these guidelines that we have laid out here? Are you on mute?
I forgot the medication example. Oh, I feel like I've let Chuck down because it is a great example.
Alberto, were you?
What's that?
Sorry?
He was on mute. Go ahead.
Oh, no, I wasn't on. I didn't have a question. I was saying you're on mute.
Oh, thanks. Believe me, you would appreciate me being on mute if you knew me personally. All right, next slide, Chris.
One sec.
Oh, sorry, go ahead, Jen.
Before I move on, does that make sense what I'm saying?
No, yeah, no, it makes sense. I think I've done past paraprofessional work and where I've had kind of explained to the parent of the client where I was like, I'm not here to cure your child. I'm more here as to act as like a sedative to aid in the treatment. Because in their mind, they're like, they sent you to basically fix all this. And I was like, no, I'm here to assist. And that's where I was like, like you said, I'm like here to act as like one medicine, but all the other services your child is receiving, that's the whole treatment.
Absolutely, Alberto. It takes the team, right? And you're a part of that team. Absolutely.
So
awesome. Could we go to the next? Oh, sorry, Jen.
No, just remember, if you take anything away as you move to your pathway to master's program, keep this one in mind. This is kind of the anchor that anchors you when you're doing diagnostics, when you are doing when you're determining how much services, because this is something that gets audited.
Okay.
Absolutely. Great example, Jen. Thank you so much. So mostly mostly it's not your problem. I swear I took QMHP out of this slide. So mostly all of that medical necessity stuff, you get to say the therapist has to handle that. I would encourage you that if they're asking you to do something that is causing an adverse reaction from the client that's not consistent with the outcome that they want to produce, that you give them that feedback, okay? Because therapists can be wrong. They can be wrong. And they also will need ideas of how you can help their client, being a new member of the team. And so you might be able to suggest to them, it looks like you're practicing a lot of relaxation skills in therapy. Did you know that I could practice those maybe in the environment that typically triggers this individual, if you feel like they're ready? Or I could go ahead and practice them with them in the community just to make them, to reinforce what you're learning in therapy. So yeah, mostly it's not your responsibility. The QMHP, the licensed person, needs to establish what's medically appropriate through conducting a service and developing a service and support plan or treatment plan, or the prescription pad, so to speak, the prescription. As paraprofessionals, you need only provide the supports and services identified in the plan, and that is at the direction of the QMHP. So it will say Alberto Duran, and it will say the service that you're providing. It will say how many units to provide, and how frequently. And that's the QMHP giving you the direction. But you have to hold on to your end of the golden thread. So have you ever heard of the golden thread?
No.
Okay, we're going to learn about it, and it is a really helpful concept. All right, next slide, Chris. So I want you to imagine that there's this golden thread, and this is representing the path of someone's illness through treatment, possibly to relapse, and then into recovery. Like our lives, the golden thread has ups and downs, knots, suddenly like goes 3 steps forward or 2 steps back or 3 back. And it has times when things go really well. This tangled thread really is supposed to represent the process from illness to recovery. All right, Chris. Thank you. She's so good at that. So here we're going to show about the golden thread in clinical documentation. So first of all, we usually meet our clients when they are in a severe illness phase. That's that knot on the far left. Somewhere after that knot, they decide to seek help, and the professional moves into assessment and planning, and then identifies services and supports through their treatment plan. And you can see that that thread might kind of go up and then kind of plateau, and then all of a sudden it starts kind of taking a U-turn and going back down. It's the therapist's responsibility then at specific intervals as defined by payers to redesign the services and supports. So they might have not had psychiatric medication management before, and that's added in. They might not have had a care coordinator to help them make sure that they could get their medications and get healthy food. And so that's added in. Mm-hmm. But the relapse occurs, after he redesigned the services and supports, there's another assessment and a little bit more planning. And then we see that, they're kind of in a relapse phase for a little bit. If they reassess, plan differently, redesign the services and supports, then that golden thread can go up again. And to be honest, all of our lives kind of look like this. But what we're looking for is a baseline where their life doesn't quite go like this, right? So they begin into recovery, and when recovery starts to happen a little bit, recovery starts to happen, we want to push away a little, right? Allow them their independence, because we're focusing on recovery and not maintenance. A little more assessing and planning might go on. Service and support redesign might go on. And then we hope that they can establish their baseline so that it's not maybe this tangled web, but with the right combination of maybe medication, therapy for specific goals, support through a paraprofessional, and also maybe some case management to take care of their social needs. Mm-hmm. We can help to smooth that out a little bit. But the important thing is that this golden thread runs through the clinical documentation. You will see in the clinical documentation, bad day, good day, terrible crisis day, normal day, normal day, normal day, normal day, little bit of a weird backslide day, but then normal again, right? So it runs through that documentation. And it's really important that when things don't go as we plan, that we reassess and plan some more. It's required by our payers, but there may be something major that happens in someone's life that means that we need to reassess, right now. Maybe down there at that bottom little twist down there by relapse, maybe they lost their favorite cat and that caused a relapse, and that cat was a social support for them. I mean, things happen in people's lives that knock their mental health out of balance. And so it's just our job to follow that golden thread. So when the objectives change for the services that you're providing, you need to change. When the dosing changes for the services that you provide, you need to change and increase your dosing. And so that's why I'm saying, like, working as a paraprofessional, you do get these opportunities to review assessments and treatment plans and understand the context of the services that you're providing and what their intended outcome is going to be. And you are going to be light years ahead of anybody in your master's class. Light years. Because you understand this. Did you have something, the golden thread, could you go back? Sorry. Did you have anything you wanted to talk about on the golden thread, Jen? I know you're hopping off soon.
No, that was a great explanation. I think that people tend to, I think people tend to think that's a very linear line from assessment to treatment, and it really isn't. And I always have appreciated this graph that our mentor, Chuck Lamecrow, had described this, and really how we as the care team to adjust, because this people just aren't predictable. They're not going to be in a linear line. So I hope that makes sense to you, Alberto.
Yeah, I know you meant, Megan, you mentioned something, how we're not doing maintenance, we're doing recovery. When does that transition really happen? Because I've been in a lot of scenarios where it seems like when or what, or, how do we transition to that, especially with, from to that, where the client's like,
there
well,
there are individuals with severe and persistent mental illness that will always require maybe psychiatric medication management, and people jumping in to provide extra services and supports along the way, or they may require those same services and supports long term. It is because those mental illnesses are chronic and they're terminal. This person will die with this mental illness. And so it's really, it's not a rarity. I wish I could say it was a rarity, that there are people that you have to maintain. But sometimes when you remove services and supports and you see people tank, when you do remove services and supports and you see people tank, you may know that for a continuous period of time, a bit higher level of support or a nominal level of support will always be needed to keep this person on the right path.
And you also have to think of it not just for mental health issues. You've got people who have diabetes, and so you've got a diabetes 2 versus diabetes 1 is very different. Diabetes 1, they're not going to recover from that. Diabetes 2, with diet, exercise, and various things, they could actually recover from diabetes 2. So there are things that will, with certain disease states or conditions, it will be a maintenance, because they're going to always need that service for the rest of their life. And it'll vary depending on the person, but even with developmental disabilities, you're going to have that same issue. And also, like really terminal diseases like cancer or other things that they're just never, like as Megan said, they're going to die with the disease. It's something that they won't ever recover from, because it is their life of living with a chronic disease or a health condition or mental health or developmental disabilities. You just have to think of it in the realm of, if you took away that service, could they live or die without it, right?
And so because these conditions are chronic, does that kind of reshape the line a little bit where there's less reassessment because it's just chronic? They're just going to need that level of care, or
It's a good question. Go ahead.
That's a very good question. And some people would argue, yes, that means that the same services are going to stay in place the same year after year after year. And that's a very unwise assumption. Just like I said, I have seen people that have been stable for a year. Bye, Jen. I've seen people that have been stable for a year and a half have their cat die and have it freaking rock their damn world because they stopped taking their medication, their symptom, they are limiting their activity, they're pushing themselves into depression. And so, there always has to be that at a minimum, if you're maintaining somebody on psychiatric meds, there should always be that follow along with the psychiatric medication prescriber at a minimum. Yeah. So does that kind of make sense?
Yeah, no, that makes sense.
Yeah. And it's just when things don't go as we plan because people are human, we need to reassess and plan more. That's our job. All right, Chris, next one. All right. So your part in keeping this golden thread from unraveling involves getting enough into your progress note to explain what you did, how well it worked, and if it produced the desired outcomes of planned treatment. If it worked well, we know we're gonna keep doing it. If it didn't work so well, we might need to reassess, check in with the therapist, come back with a better plan, or do something a little bit differently. Now, let me put it this way. That doesn't mean that the first time you try a skill with someone and it doesn't work, that you go back to the therapist and say, it doesn't work. What you do is you try to use more of your own clinical skills, maybe put on some radar, maybe try a new environment and try to execute that skill or execute that service in a different way. So, but that is your job, is your note, really the quality of your note. It is, if you think about it in a pyramid, there's only one assessment, at least to start. There's a few more treatment plans than there are assessments because they're supposed to be updated every 6 months. And then there's all of these progress notes. So it's like a pyramid. And your progress notes, the therapist progress notes, the psychiatric medications progress notes, those are the base of all of your documentation. They are, or not the base, they are the foundation of reporting improvements or challenges. So, all right, next slide, Chris. All right, so I would like you to read this out loud. Alberto, can you see it?
Yeah. So Billy is an 11-year-old who was removed from his home by child welfare after it was learned that his father had severely beaten his mother while he watched. In school, he has been caught bullying other children. There is no stable adult male to provide a healthy role model in his life, or a health role model in his life. As part of his treatment, he is assigned a PSR who is supposed to spend Saturday mornings with Billy, engaging in health activities and help him develop more positive relationships with his peers.
All right, next slide, Chris. I think that, okay, don't show anything there. Oh wait, yeah, don't show anything there. So go back, sorry, go back. Do we see our golden thread here from the brief assessment that we have to the assigned service and support?
Assigned service and support. I see more of the assigned service than the assessment, other than who's just assigned a PSR.
So the assessment would be, that he was removed from his home, the symptoms that he's expressing. So this is just like this is not a real assessment, but it's a mini assessment. But yeah, so assessment is kind of the first box. as part of his treatment, he's assigned a PSR. So he has a diagnosis of some kind, or he wouldn't be in treatment. Who knows, it looks like he's been disruptive at school. He may just have an adjustment disorder. Who knows? Okay. All right, next slide. So these are 2 examples of notes that you could write for your time with Billy. All right, so in your note, you say, oops, sorry, go back. Today, Billy and I went fishing. We talked about stuff and we each caught a trout.
Do you want me to say what's wrong with it?
Yeah, tell me what's wrong.
It's vague, it's short. It doesn't include what they talked about. It doesn't include how this is teaching him how to maintain healthy relationships with peers. So it seems like it's just like yeah.
It is, so you are hitting the nail on the head. The goals of providing Billy with a PSR was to support peer socialization and positive health activities. So they did a healthy activity, right?
Mhm.
But did he write that he did a healthy activity? No. I mean, what he has to say is, for a healthy activity today, Billy and I went fishing, right?
Mm-hmm.
Yeah. And then I'm not going to rewrite it yet because we'll rewrite it totally later. Okay. So good call. It didn't integrate any of the objectives. The one thing I would say is, if this was your first meeting with Billy, maybe the objective for the first meeting was rapport building. And so you could be writing about that. But for the most part, this does not hold on to your end of the golden thread. Let's try the next note. Let's see how that goes.
Do you want me to read it? Oh.
Yeah, go for it. Sorry.
Yeah, it's better.
Yeah. Today, this is so I'm just gonna ad hoc what I would change in it, but this is a lot better. Today, Billy and I went fishing as a healthy activity. We talked about a lot of things, including his favorite subject at school, whether he'd gone fishing before, you could stuff like that. You might point out a few things. We talked about the time, some ideas of time that we would be spending in the community, some other healthy activities that we could do. He seems to be gradually warming up to me, but he still won't talk about how he's doing in school or why he keeps getting into fights. So he just reported back like, we went fishing, talked about a lot of things, that we each caught a trout. He's gradually warming up to me. And this would tell me, this is their first meeting. They're establishing rapport, but you still go back to the problem that you're treating, which is the fights in school. And you're still using you're still providing the services that were defined, that positive health or healthy activity, not quite doing peer relationships, but you don't have to do every objective every time. Okay. You talked about his peer relationships, which might be good. So, all right, next slide. Here is example 2. Mary has just been discharged from a long stay in the state hospital. She's never lived alone, but now has an apartment for the first time. Unfortunately, she's never learned to cook. Part of the service and support plan calls for a community health worker to help Mary shop for food 3 days a week, then help her prepare a nutritious meal. All right. So do we see the assessment and the service plan and the services that are being prescribed here?
Yes.
Yeah. Definitely. All right. Here's the note. Mary and I went to the grocery store and bought everything we needed to make popcorn. Okay. When we got back to her place, we cooked it up with lots of butter and salt and watched the movie on TV. It was great. So what's wrong with this?
I mean, there's so much wrong.
Yeah.
Like the other one, short, vague. It doesn't follow the treatment plan because I mean, you can't. I mean, you don't cook popcorn. I think you put
Popcorn is not a meal. It
yeah,
is
it's
not
not
a meal.
nutritious. Yeah. So I don't think she really learned anything from that. And it looks like when they went to the store, that's all they bought from what I see.
Yeah. Okay. Yeah. That's not a good note. It's not a good service either.
Mhm.
Not a good service. Let's check the next one. Oh, yeah. We can make it a lot better. We figured this out. Mary and I went to the grocery store and bought things to make a salad and grilled cheese sandwiches. In preparing the salad, she was a little hesitant, but with coaching, she was able to use a knife. Sorry. I had to do some coaching about paying attention to the stove, but she made a great meal and was very proud of herself. Next time, we'll learn how to make soup.
Okay.
Goes right through it. So meal prep and shopping. Excellent. Excellent note. All right, here's our third example. Crystal, you get to read this one.
John's meds are causing him to gain a lot of weight. He is very shy and is often too afraid to leave his house, so he doesn't have friends and gets very lonely. His psychiatrist wants him to get more exercise to help prevent further weight gain, and his therapist feels it's very important that he spends at least a little time in social contact with others every day. A paraprofessional is assigned to go to John's house for about 45 minutes, 4 days a week. The plan is for the two of them to go for a walk with the hope that the paraprofessional can help him become more comfortable socializing with others.
This is definitely something you could be called on for a BHC.
Mhm.
All right. I'm going to make you read this, Alberto, because I'm an equal opportunity torturer.
Okay, so I went over to John's house at the usual time, but at first he said he really didn't want to go for a walk with me. But he agreed to come out and sit on the front steps with me for a while, and we talked a little about how he's doing. After a while, we decided to go to a movie which we both enjoyed, me especially because I needed to get in a few more hours of work this week. The service reported as taking 3 hours and 40 minutes. What do you think?
Okay, so first of all, I'm just going to ask, did he meet the objectives?
No.
He tried though, right?
He
And he
did
talked
try.
about why. Yeah, he tried to get him out to take a walk. And yeah, so and did he get him to socialize? It's a low level of socialization, but it is socializing, right? So
mhm.
he worked on the objectives. What's wrong with this note? There's nothing wrong with it, right?
Well, isn't one of the criteria that the service can't benefit you either? Yourself as a paraprofessional?
Right, so that part in there about him getting extra hours of work this
I'm
week, that
frozen.
would be inappropriate. I'm not sure if we're losing Megan. We're not hearing you, Megan.
Sorry, I was frozen. Alberto, did you mention what might be wrong with this note?
Yeah.
Okay, yeah. The service is reported as taking 3 hours and 40 minutes, and it's provided for the sole convenience of the provider. The movie, yeah, so 45 minutes. That's the dosage that was given to the paraprofessional. He exceeded it. All right, next slide. Something like this would be better. And it actually changes the session a little bit. So what about this one? Go ahead and read this one, Alberto.
I went to John's house at the usual time, but he said he didn't really want to go for a walk with me. At first, he didn't seem to even want to let me in, but after a while, he agreed to come out and sit in front of the steps with me. I think we're making some progress because he seems to be getting a little more comfortable talking with me. So that's good, even if he's still not getting enough exercise. Service is worried about taking about 45 minutes.
Right. And so the client declined to do the walk. That's okay. It took 45 minutes. This is a good note. This is a good note. All right, next one.
Megan, do you want to do your 5-minute break?
Oh, crap. Yes, let's do a 5-minute break, guys. Sorry, I got so excited. Where are we going after this, Chris?
I didn't mean to pause sharing. I meant to pause recording. It'll be
Okay,
ethics after this.
Perfect. All right, let's take a 5-minute break and then we're going to talk about ethics.
Okay.
Okay. See you back here at 9:21.
Okay.
And I think, Megan, you'll have to pause recording. I don't have record pause permissions.
I will do that. Thanks for reminding me.
Yep.
All right, so paraprofessional ethics. We got to go to a couple slides forward, it looks like.
Oh, looks like it went backwards quite a bit. Oh, there we go.
All right. So there are some general principles of ethics that you should think about as a paraprofessional. Like I said, I've never Googled care coordinator code of ethics, and that might be like some homework I'm going to give you. Who knows? Let's do that. Let's do that. Or paraprofessional code of ethics. Maybe there's something else out there like that. So honesty and integrity. Service notes are legal documents. They can be brought forward in an injury case or in a child custody case. So many different areas that that they are called upon. What you write in them must be an accurate description of what happened. You should accurately report all relevant details, especially where the service took place and how long you took to provide it. Obviously, we went through that big list, right? And nobody is perfect on their notes or on their sessions. So if you screw up or make a mistake, tell your supervisors so they can help you fix your problems in your sessions or in your notes and help you learn from them. So honesty and integrity, it's very important. I don't want to give examples of what being dishonest is, but I'm going to give one. I had a paraprofessional that I supervised, and they pretty much did the same activity every day. And I found out she was just cutting and pasting her notes. Really, really helpful, really, really helpful. And it was, we had to back them all out of billing.
It wasn't me.
No, it wasn't you, Crystal.
I just want to make sure Alberto knows. Nope, that's not me. I am a big proponent of creating templates that you can copy and paste from, but not when it comes to documenting your activities for the days.
Yeah, exactly. And it is a matter of honesty and integrity that you write down when you screw up as much as when you do well. And so I'll give you an example of that. I had a young man that I was assigned to spend time with, actually 4 hours a week. It was wonderful. 4 hours is a chunk of time I can do. We had a session and we were newly getting to know each other, and his mom was fairly hyper vigilant, so she came with us, which is fine. And we went to a local park. We walked to a local park. His mom and I were sitting at a park bench while he was playing on some playground equipment. He decided he needed a drink and he headed over to the drinking fountain and he stuck his finger in the pipe that came out of the drinking fountain. They had removed the mouthpiece for winterization. Okay, I screwed up. Okay. I let him out of my sight and he got stuck. His mom started freaking out. We were calling, she was wanting to call the fire department. Okay. Luckily, fast thinking, I had a thing of chapstick and I lubed his finger up and we got it out of there. But it was still something that I reported in my note. And it took like an extra 15 to 20 minutes and we were pretty close to the end of our session at that point. And so I did document the extra time in the session and just, worked it out for the rest of the week. But yeah, we all screw up, and hopefully they're mostly harmless screw ups, but sometimes they're just things that you want to improve on. So it's okay to talk to your supervisor or the cases supervisor. Next one, Chris. All right, so as a paraprofessional, you become part of a treatment team of professionals and other professionals whose job it is, paraprofessionals whose job it is to help others. This raises some thorny questions. How does it change your relationship with those who are trying to support you and your client? So, and how does this change your relationship with those that you are trying to support? Especially around integrating people with lived experience in substance use disorder. You may have worked with this person as a client before. I have hired clients for positions within my agency as paraprofessionals. Let's put it this way. I told you my story. When Jen hired me as a paraprofessional, I was very fortunate because she talked to me about how it would change the relationship that I had with my therapist, who is still currently working at the clinic, and with my psychiatric provider. And so it's just important to think about those things, that the relationships, maybe the person sells Avon and you're not going to buy Avon from them anymore. Maybe they used to be your Scentsy candle lady. I don't know. It just depends. It does change your relationships, especially in small towns. That individual that I told you that consistently Facebook friend requests me, I'm very close friends with his mother and I'm a colleague of his mother's, but it does change the relationship. So with those people around you, to the point that sometimes you may need to disclose that you have a relationship with an individual, so that the therapist can assess whether that would be a dual relationship for you, and whether it would be too difficult for you, especially serving family members, etc. Okay. All right, next one. Okay. You have to be careful to protect the confidentiality of PHI, right? So when the parent wants to debrief with you in the grocery store, yeah, you got to run. Got to tell them we're going to do it another time. Also, you may have an experience with a client that you really feel like you need to debrief about. The best person to debrief with about that is not another paraprofessional, because there's PHI contained in that. You do not know if that other paraprofessional has a relationship with that individual. Go to your supervisor, okay, and debrief, or to the person that you're assigned to bring problems to, that potentially that clinician of the client you're working for us. So even then, we're only sharing the minimum necessary and on a need to know basis. You should assume that within your team, there's pretty much a need to know basis, okay? If someone tells you, I don't want you to tell anybody about this, but blah, 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 you have to tell them, we are, in a session right now, and I do share this information with your therapist. So, and sometimes that's a difficult conversation to have if they've already shared. So you may say, appreciate that you shared this with me and you don't want me to share this with your therapist, we will work on, let's do it together if that would make you feel best, right? If you felt comfortable telling me, maybe you would feel comfortable telling your therapist if I was there to support you. So, next slide. Boundaries, which we talked a lot about, right? Yeah, so you have to understand the boundaries of your competence, your training, your skills, and not provide services for which you're unqualified for. So I think I used the diabetes cooking class as an example for. That doesn't mean that you can't be upskilled and that the clinician can teach you how to teach a skill that they're working in therapy. It doesn't mean that you can't go to trainings and learn how to deliver curriculums. It's just that you have to stay within your level of knowledge. This also kind of requires respecting the judgment of those who have a higher level of qualification. So there may be times that you disagree. The best place to voice that disagreement is with your supervisor so that you can plan a way to share information that may lead a primary clinician or a psychiatrist to a different opinion, all right? That doesn't mean you can't question authority. Just don't do it in front of a client, in front of a colleague, and go to your supervisor first. Next slide, most ethical challenges, in fact, Alberto, are things that you should be discussing with your supervisor. So more boundary more boundary things. So we talked about a lot of these, keeping secrets, no sexual intimacy with patients past and present, no bartering. So if you do a good job on your if you do a good job on the shopping trip today and don't buy any candy, then I will, okay, don't barter with clients, don't bribe them either. And then dual or multiple relationships, as we've talked about before. Probably one of the most important slides is that when we become helpers of others, we must be acutely aware of when we need help and when our need for help is greater than our obligation to serve. So just like all other clinical staff, you should be alert to signs of stress, burnout, fatigue, maybe family problems that are getting in the way. And you should ask for assistance at the earliest stage so that your performance doesn't become significantly impaired. I would, recognizing that problems can emerge at any time in someone's life, I make it very clear to my supervisees that they can contact me at any time for support, because I want to not be their therapist at all, but I want to help them troubleshoot any problems, whether they're sick, whether they're having a really crappy day. Maybe they actually have a behavioral health disorder and they aren't managing it well. They need to report those things to their supervisor. And that is why, relationships with your supervisor are so important. I wish I could give you a slideshow on how to build a great relationship with a supervisor, but I don't have one of those. But next slide, Chris. Yeah, and it all comes down to the Hippocratic Oath, right? That we avoid harm to the people that we seek to help. So I have called in and said, I am not ready to work with this kid today. My frustration level is too high. I have called in and said, I had a death in the family. I need time away. I've called in and said, my basement's flooded and my brain is shot. Even working from home, I have called in to avoid harm to the people that I'm trying to help. So the Hippocratic Oath, of course, above all, do no harm. I'm sure you've heard that. And when in doubt, seek supervision. And actually, it's those small moments of those nagging things in your brain and those small moments of self-disclosure to your supervisor that I think really build that trust, that you trust them to take care of you and listen to what your challenges are, and you trust the feedback that they're giving you as well. Whether it's a challenge with a client or a personal challenge. All right. Next slide, Chris. All right, I'm gonna cry. This is the best advice that I can give you around paraprofessional ethics and around documentation. And it all comes back to this man. And I just have to, this is in memory. Jen and I both present this with great respect in memory of this man, Chuck Lane Crow, who was our compliance officer and also our very good friend. And so just wanting to give a note to him. So
That's it.